also to enhance your safety, and also look into eye as such when you're doing surgery, what are the various dynamics which can happen, which can change your concept of visualization during surgery is so important in these cases also. This is what we have been doing regularly. We have been telling our students to examine your patient very, very carefully, do good selective examination. This is a white cataract. Look for anterior bulge of a capsule, that is a sphericity of convexity of anterior capsule. Look for an anterior chamber space, especially peripheral areas, because periphery can be so shallow sometimes, it may be difficult to enter. Look for intralenticular clefts, and these are important guidelines. But if you do same patient under anti-segment OCT, which most of us have, the assessment is needed in these cases. You can document this patient appropriately, the anterior convexity, the fiber, the clefts, everything can be seen in these patients. In fact, you can define better, which may not be, sometimes difficult to replicate the examination by two examiners the same way. But OCT picture, if you have, you can have time, you can assess these patients appropriately, plan your surgery accordingly also. So we do have various methods to see the entire morphology of cornea, cataract, lens, and other areas also. You have a pre-op anti-segment OCTs, high definition one we have nowadays. Intraoperatively, if you have intraop microscope which has the OCT attachments, or if you are using a femtosecond laser devices, they have all OCT related pictures which can again image your entire profile of the anterior segment in these cases also. This is our review article on microscope integrated OCT in cataract surgery. This was important at that stage because everybody was talking about IOCT microscope is meant for only for retina people. So we shifted the concept that it is good for anterior segment surgery. In fact, now it is more used for anterior segment surgery than a posterior segment pathology also. The other important thing we realized while using the intraop microscope was it makes you to understand the changes happening with each step of your surgery. Suppose I make an incision, I can see the incision right from the beginning to end, which was not possible earlier. You could see the incision next day when you do anterior segment OCT, that you have distorted, you are damaged, you have a decimal moment detachment. That was only possible after next day if you take the patient to anterior segment OCT. This entire thing you can see now. You have done a uniplanar, biplanar, triplanar incision can be seen beautifully here. And most importantly, it is very helpful in challenging cases. Let me take you through two important areas of cataract, which is white and posterior polar cataract. White cataract, you all know, because of absence of red reflex, the axis becomes very, very difficult, challenging. That is one part. Second part is we don't know which are those cases where actually you have an increased lenticular pressure. That is also important. If you realize that before surgery, you can plan your surgery accordingly. You can do aspiration with needle, you can do a puncture, you can do different types of application like femtosecond, Jepto, or a capsule laser can be planned in these cases also. So this publication came in late 2000, I think 19 or 20, where we classified the entire gamut of white cataracts by doing the intraop OCT imaging for these cases. We classified them into four categories, but you have the spectrum of white cataracts in between these categories also. The advantage of this classification was you could make your surgery according to this. I know that not everybody will have an intraop OCT microscope, but this image is replicated by anterior segment OCT. In fact, this is replicated by slit-lamp examination also. So if you understand this, you can replicate this into your practice very effectively also. So this was based on the two important areas. One was before intervention, second was after intervention. So we looked into convexity of anterior capsule, looked for arrangement of fibers, lamellae, and looked for an intra fiber clefts in these cases or a homogeneity of fluid in these cases. Second part was the dynamicity, that is flattening of anterior lens capsule after injection of viscoelastic, what happens, how much flattening happens, the dynamicity of initiation of initial nick or a capsular axis, the disturbance of underlying cortex and release of fluid, which may be milky, which may be turbid, which may be no fluid also. Based on that, we did a classification. This imaging gave us the idea what should be done. Like this patient has a very regularly arranged lamellar cortical fibers, no clefts in this. everything is very homogeneous. It seems that there may not be increased lenticular pressure. You can just see once we make an initiation of capsulorhexis, nothing happens, no fluid release. So this patient, you can rightly do a normal capsulorhexis. You don't have to intervene with any other procedure by going through the needle aspiration or doing other devices. This is a good case for a femtosecond laser application also. This was type 1. Type 2, we classified them, which is normally in a younger age group patients, where you have intumescence, hydrated lenticular fibers going across the length of a lens, right from the one end to other end, and you have thick cortical fibers, and the clefts are underneath that. In this particular case, as you initiate the opening here, the entire fiber bulge out. They don't let the fluid release because the pockets are underneath these thick fibers. And these are the cases where peripheral extension is very, very high. If you go little more peripheral, the extension is 100% in these cases. What is to be done here? Make a smaller opening and aspirate this with the bimanual cannula, what you see in this video. In fact, this video won a best of show in American Academy a way back, I think 5-6 years back. So I'm seeing that this is a bulge which has occurred. I'm really afraid now. I have to block the peripheral area, inject little bit of dispersive viscoelastic which maintains the pressure, then make a small opening, aspirate now with a bimanual aspirator. That will decrease the pressure by making this convexity to concavity. Now you can fashion the rhexis accordingly, comfortably with micro forceps or a needle also to a size where you can do a nice nucleotomy and implantation in these cases. The thing to learn here was if you have thick fibers, needle aspiration may not work. There you have to break these fibers, so require a larger aspiration with cannulas. This is a type 3 where you have a combination of hydrated fibers, clefts, and little fluid. In fact, these group of cases are maximum we see in a younger patient also. As soon as you make a nick, there's a release of turbid fluid, sometimes like an oily fluid in a little amount. Even that little amount release causes a decrease in the pressure of a lenticular pressure, and you can do a normal area. I feel this is a case where needle aspiration really very helpful in these cases because you can aspirate the fluid very effectively, and rhexis becomes very, very comfortable in these cases. Type 4 is totally filled with the fluid. This is going towards a hypermaturity or Morganian cataract. You make a nick and entire milky fluid comes out, pressure goes down immediately. So this particular case, even you don't do anything, nothing will happen because initial nick also will release the fluid. Only thing, the initial nick has to be very, very small. Don't make a larger nick, otherwise this release will block the visibility and sometimes the tear can extend. Make sure entire fluid is taken off before you initiate the rhexis, good staining, and sometimes you may have to maintain the pressure of capsule to be torn. You may have to inject viscoelastic underneath this also. So this classification can also be seen in the femtosecond laser devices also. You can see while looking for a OCT picture in a femtosecond, you can see the entire configuration. You can homogeneous ground glass appearance there, which may be type 3 or type 4 type of picture. But if you apply the laser, the fluid will get released in this particular case. You can see the fluid is under pressure, it will get released at the breast. So that can also be seen that I know that this particular patient will have a gust of fluid release. In the operation table, I'll have to stain the capsule and take out the capsule in a manner where normally you do a capsulorhexis in these cases. And you can see the thick cortical fibers are not broken even with the laser application. So we have to be a little careful in these cases, even after application of femtosecond laser in these cases also. So this is a classification which gives us the idea that you have to see, and accordingly you can manage these group of cases. In fact, now we normally look all these cases through anti-segment OCT before we take up for surgery for these cases. Look for a type of white cataract you have, and look for a intralenticular pressure rise. Then, if possible, image them and do surgery accordingly. So what we have learned in the white cataract is all white cataracts may not have a raised lenticular pressure. It depends on its morphology per se. The second part which I'm going to take you through is the posterior polar cataract, where we have done a lot of studies also. And there also we are not sure which are those cases where axial posterior capsule can be weak or opened up before surgery also. These are various pictures you can see of posterior polar cataract classically seen. There also we have to see the important morphology which can be high risk factors. So this is a study published by one of my younger colleagues, where we did consecutive 100 cases of posterior polar cataract. We did an anti-segment OCT and seen with a high definition, seen the configuration morphology of these cases. So we realized there are three important features. This feature you can see in a slit lamp also. So if you have a conical shape, this is the posterior polar disc, and the entire posterior part is a conical shape. This is moth-eaten appearance, and this is the eclectic appearance. These three morphology in anti-segment OCTs are classified as high-risk cases. This we say because if you have these morphology, which is seen around 10% of cases, you have very high chances of posterior capsular opening during the surgery. Remaining 90% of cases have a generalized morphology, where the chances of posterior capsular opening is very, very less. This is what we always debate, should we do a hydrodissection or not? I can say if you have this morphology, then you should never do hydrodissection. But if you have a generalized morphology, you may be able to do hydrodissection, and surgery becomes simpler and faster in these cases also. Similarly, we had more than 40 patients where we did an intra-op OCT guided classification in a similar way, where we looked into a clarity or a delineation of a posterior capsule underneath the disc of a posterior polar cataract. If you could delineate the capsule centrally also, this is type 1. And if you could not delineate the central area, that is type 2, periphery could be delineated. And this all depends on a size and the thickness of a posterior polar cataract in the central area also. Just to show this type 2 variety where we don't do a, normally the hydrodissection, we are doing a delineation here. See what happens after delineation. There's a fluid here. This is endonucleus. This is the epicortical cushion we have created here. Decompress, the fluid will go off, which is very important in cases with posterior polar cataract. In this particular case, the second fluid wave went to a hydrodissection phase. You can see there is some hydrodissection happen. So even you have a hydrodissection, when you are doing actual surgery, don't try to rotate the entire complex. Try to just handle the endonucleus only. In that way, you can safeguard your posterior capsule in these patients also. Type 3 is a moth-eaten appearance in anti-segment OCT. Here, you can see you cannot delineate the entire range of a posterior capsule, and surgery can be very difficult here. These are cases, they have a harder nucleus. Even a delineation becomes difficult in these cases also. So this is a more challenging, and the technique of the internal hydrodelineation may be very useful in this group of case, where the actual delineation doesn't happen completely. So after we make a trench divide, then the delineation can happen in these cases also. So there, if you don't have to do a hydrodissection, don't have to rotate your nucleus, then this technique of ours, chop and table nucleotomy technique published in IGO, is very, very effective way. So this is a delineation now we are doing, which is separate the nucleus core from the epicortical area. And like this is the core now, this is the epinuclear cushion, and the entire surgery is related to this central core only till you effectively eat out this. If you see here, we have done just a delineation. Central area is now created. This space will allow the internal hydrodelineation happen. This is the space here. The fluid goes, shifts in around surrounding area to create multiple delineation, and surgery subsequently become very, very effective also. Now, I can just pull the piece to the center. You can see this is without disturbing the epicortical cushion. I have selectively delineated the core of a nucleus to center, and this is safeguards the posterior capsule. You follow this technique, you will never have a posterior capsule opening during your surgery. It might open up subsequently when you take out the epicortical cushion, and that is not going to give you any drop in the nucleus to the posterior capsule. This is the enhancement of visibility with the femtosecond laser. This is the posterior polar cataract. You can scan the posterior part also. This is our technique after Avay talked about rings of safety. We combine this with the chops also. The hybrid technique, 3 rings of delineation and 8 chops gives you 3 layers of blocks of nucleus. This is one primary, secondary, tertiary with epinucleus. And surgery becomes very, very effective in these cases also. So how you can see this imaging changes your concept of surgery is very important. And this is what I talked about. You can see what type of incision you have done initially with the OCT microscope. What happens after your hydro procedures? What happens after your nucleotomy, irrigation, aspiration, implantation? And you can assess the most important area, that is near the incision, the wound side descemet detachment, which can happen, which can extend also. This is one of the classical video I have from one of my patient with interdigital compromise case, Fuchs case. I've done a phaco effectively in this patient. With the hazy cornea, implanted the IOL monofocal lens. And when I was doing hydration in this particular case, I realized this is one side, this other side, little bit of frill I could see when I hydration here. I opened up my OCT microscope. I could realize there's a wound side descemet detachment. I thought, let me shift this cursor little towards the corneal side. I realized the detachment was quite big. So if I had no OCT picture, I would have left like this, and next day entire descemet would have detached. You can see how big is the detachment here. The imaging in such cases is very, very important and really saves the day for you. And with air injection, for keeping that for another 3 to 5 minutes, the detachment got settled down, and next day patients are all right. So I can summarize this. Please don't think that I am just showing the IOCT microscope. Replicate that image to OCT, anti-segment OCT imaging. Replicate that to your straight-term examination. You'll do better in your surgeries. So it is very useful in corneal surgeries, useful in assessing the wound areas, useful in a refractive surgery like smile, lenticle-based surgeries, as well as ICLs also. Cataract surgery, yes, it is very, very definitely advantageous to image your cases before surgery, intraoperatively, and postoperatively also, and change your concept. Thank you for your kind listening for this talk.